You know the feeling. A patient says they're always tired, and your mind just explodes with a million different possibilities across a dozen organ systems. Well, today, we're going to cut through that noise. We're going to build a powerful mental model to systematically tackle exercise intolerance. It sounds so simple, right? I get exhausted walking upstairs. But behind that one sentence is this huge, sprawling list of potential causes. We're talking heart, lungs, blood, muscles, the whole shebang. And look, the key isn't to just memorize that list. It's about having a system, a framework to navigate it.
So here's our game plan. First, we'll nail down what the complaint actually is. Then, we'll build our core framework around something fundamental, the oxygen pathway. From there, we'll see how that chain can break, how to search for clues, and finally wrap it all up into a clinical framework you can actually use.
All right, first things first. Let's be honest. The word fatigue is, well, it's notoriously vague. So to make any real progress, we have to get really precise about what our patient is feeling and what we, as clinicians, mean by exercise intolerance.
This is so important. We're not just talking about a subjective feeling of being tired. Clinically, exercise intolerance is the inability to do something you should be able to do. It's a real, measurable physiologic state, and it's a huge red flag for everything from heart failure to post-viral syndromes.
Now, your patient probably isn't going to say, I have exercise intolerance, right? They're going to give you these clues. Getting unusually breathless tells you the demand for oxygen is outstripping the supply. A racing heart, that suggests the pump is working like crazy to keep up. And that deep muscle fatigue or pain, that tells you the engine itself might be failing. These are the puzzle pieces we're about to put together.
Okay, so here's the core idea. Instead of trying to memorize a massive list of diseases, let's build our entire approach around the one thing that underlies all of this, oxygen.
And here it is, this diagram from the source text. It lays out the whole system. Don't worry about every little box. Just follow the flow. See the arrows? From the air we breathe, down through the lungs, pumped by the heart, and finally used by the mitochondria in our muscles. The crucial insight is this. Exercise intolerance is simply a failure at some point along this pathway. That's it.
So let's simplify that diagram into a 5-step journey. This is our clinical map. Step 1, ventilation. You got to get the air in. Step 2, diffusion. The oxygen has to cross into the blood. 3, transport. The heart's got to pump it out. 4, perfusion. You need to deliver it to the right muscles. And finally 5, utilization. The muscles have to actually be able to use it. Our job really is to be detectives and figure out which of these 5 steps is failing.
Okay, so if we know the steps in the chain, we can now use this exact framework to build a smart, organized, differential diagnosis. No more random lists of diseases. Now we can group things based on where the chain is broken.
And you know what? The source material makes it even easier for us. We can boil this down into 3 main domains of failure. Is it a problem with the lungs, ventilation and diffusion? Is it the heart, which is all about transport and perfusion? Or is it a problem down at the level of the muscle and blood, which is all about utilization? This simple lungs-heart-muscle framework, that's our key.
So if it's a cardiac problem, we're basically talking about pump failure. Maybe the heart's too stiff to fill up properly. Or you get this thing called chronotropic incompetence, which is just a fancy way of saying the heart rate literally can't speed up enough when you exercise. No matter the cause, if the pump is weak, the whole system down the line is starved for oxygen.
Now, what if it's a pulmonary problem? Well, here, the issue is happening right at the start of the journey. You might not be moving enough air, or the oxygen you do get in just can't cross from the lungs into the blood effectively. It's like the pump is primed and ready to go, but there's nothing for it to pump.
And finally, we get to the engine itself, the muscles. The lungs and heart could be working perfectly, but if you're anemic, you just don't have enough oxygen carrying trucks on the road. Or maybe the tiny blood vessels in the muscle are messed up. Or you can go all the way down to the most basic level. The mitochondria, the little powerhouses in the cells, just can't use the oxygen being delivered. The fuel's arriving, but the engine is broken.
So, we have our framework. Lungs, heart, or muscle. The million-dollar question is, how do we figure out which bucket to put our patient in when they're sitting right in front of us? Well, this is where good old-fashioned clinical skills come into play.
And here's some really good news. Most of the time, this isn't some esoteric, mysterious diagnosis. The source text reassures us that the vast majority of these patients will have clear, obvious signs of cardiac or pulmonary disease. The clues are almost always there in the history and physical exam, if you know what you're looking for.
Okay, this table right here, this is incredibly high yield. Just look at how beautifully it separates the two most common culprits. A history of waking up breathless at night, that's orthopnea, that just screams fluid backing up from a failing heart. A chronic productive cough, that points you straight to the lungs. And the exam findings are just classic. Rails from fluid in the lungs because of heart failure versus wheezes from narrowed airways and lung disease. These are the clues that let you pinpoint the problem.
Now, to really see how this all comes together, let's zoom in on a classic and, let's be honest, often a very tricky diagnosis: heart failure with a preserved ejection fraction, or HFpEF.
And wow, this just illustrates the complexity perfectly, doesn't it? HFpEF isn't just one problem. It breaks that oxygen pathway at multiple points. The heart muscle itself is stiff, it can't speed up properly, blood flow to the muscles is impaired, and there are even problems happening inside the skeletal muscle cells themselves. It is a perfect storm of physiopathology.
Okay, let's wrap this all up. Let's distill this down into a simple, repeatable process that you can actually take with you on the wards.
Here it is, your 4-step approach. Number 1, define. Get super specific about what the patient is telling you. 2, map. Mentally place those symptoms onto that oxygen pathway we talked about. 3, differentiate. Use that map to build your differential around the big 3, heart, lung, or muscle. And finally, number 4, localize. Hunt for those specific history and exam clues that point you to the right category. If you only take one thing away from this explainer, let it be this: you do not need to memorize every rare cause of exercise intolerance. What you need is a system, a powerful, physiology-based framework that guides your thinking from a vague complaint all the way to a specific diagnosis. So, the next time you're faced with this really common challenge, don't just think about a list of diseases. Think about the oxygen pathway. Look for those specific clues in the story and the exam, and ask yourself, what subtle clue is going to reveal the broken link? You find that link, and you'll be well on your way to helping your patient.